Dr. Beckwith. I have my clinic in Leesburg, Virginia, and I invited today my husband, Dr. Beckwith, who's the primary care physician, and we have two different approaches to evaluating the patients. And so I wanted to start with my introduction to Dr. Matthew Beckwith. So tell me, please, how long have you been primary care doctor?
Yeah, I'm a family practice physician in Hagerstown, Maryland for 26 years.
And what's your training?
I went to medical school at the University of Texas Medical Branch in Galveston and did my residency at the University of Florida Health Sciences Center in Jacksonville.
And so I am actually emergency room physician by training. I went to University of Vermont Medical School, and I went to residency at Johns Hopkins for emergency medicine. But I do practice now urgent care and family medicine together with my husband. So we have two different approaches to evaluating patients. And I wanted to first ask, let's say we have a hypothetical patient who is about 30 years old, it's a female, and presents with abdominal pain. How would you approach that?
I'd probably refer her to you.
Okay. So,
No, I would, well, there's a whole lot to it. Abdominal pain is extremely complicated. I would have to get a really thorough history and do a good exam. But then after that, I would narrow down my scope to what are all the different possibilities, and that's called a differential diagnosis. And then I would figure out what tests need to be ordered for each one of those items on the differential diagnosis list, and then I would order the appropriate test. That is, assuming that the abdominal pain were not something urgent or emergent that required immediate action.
So let's narrow it down. Let's say your physical exam didn't really pinpoint anywhere. It's just kind of a generalized abdominal pain, no vomiting, no diarrhea, no fever, and the pain is intermittent for like 3 months.
Okay.
So what would you order?
Well, once again, I would make a differential diagnostic list of all the things that could possibly be the problem, and then I would just go down the list.
Okay, so are you able to do anything in the office, like order blood work and actually see the results right away?
No, absolutely not. Well, I mean, there are certain things we can do in the office, but basically, in outpatient primary care, we don't really have the ability to do the things you can do in an urgent care or an emergency room to get results right away. We can do urinalysis to see if the patient has a bladder infection or a urinary tract infection. There are a few things we can do that have nothing to do with abdominal pain, but we do not do x-rays, and we certainly don't do blood work in our office and get immediate results.
And no ultrasound, no CAT scan.
That's right, no imaging at all.
So that's the difference between the way I approach the workup of the same patient. And my differential diagnosis will be for the pain that it's so non-specific and long-lasting. It could be anything. Could be gallbladder, could be kidney stones, urinary tract infection, ovarian cyst, and so on.
Irritable bowel syndrome, inflammatory bowel disease, mesenteric ischemia, what else? A million things.
Appendicitis, chronic appendicitis.
Yeah, chronic pancreatitis, chronic hepatitis. Oh man, there's a million of them. And then of course it might not be an abdominal problem at all. It could be
Pneumonia.
That's right, or it even could be coronary artery disease. It could be something in the pelvis, since it's a female. We could think about uterine or ovarian problems. And of course, urinary tract. You talked about kidney stones. By the way, I think there's something we should clarify. You said we're in practice together. We're not in practice together in the same practice, but I am a consultant in your practice.
Right.
But I don't see patients at your practice. So when you need me to consult on something or to oversee somebody else who works there, practice, I'm available. but my practice is in a completely different location in a different setting. So in your practice, you actually have blood work. You can do blood work and get the results right then.
Yes, and I do the ultrasound and I do X-ray. Um, I can do I can do also treatment. I can do IVs and I can give medications. So it's completely a different kind of setting where the answer is given almost always right away. And that's the beauty of availability of those things in my clinic, and also my approach to the working up the patient based on the entire body. Like I understand that the patient came with abdominal pain, but as you said, it could be a million of other things like heart attack, or it could be, cancer somewhere. And
That's right.
I basically just do my general evaluation by looking at every organ I can possibly see within a few minutes.
So you can rule out, you can look at the gallbladder. What other kind of things would you see in the abdomen that would be?
Well, I can see kidneys, spleen, liver, gallbladder. I can see pancreas, but pancreas is very difficult to see the whole pancreas because it's retroperitoneal, and ultrasound is notoriously bad for evaluating retroperitoneal organs.
Right. We should explain what retroperitoneal means. It means it's in the it's behind the abdomen. There's an abdominal cavity and there's a peritoneal cavity, which is where the kidneys also are.
Okay, and then I can evaluate in men prostate, in women it would be ovaries and uterus. I really cannot evaluate bowels because bowels, they're constantly moving and they're large, so you can't evaluate them without.
Ah, okay. Well, now you also have X-ray though. An abdominal X-ray can tell whether a person's bowels are backed up.
Yes, you can do that.
Which is a very common cause of chronic abdominal pain, just constipation, believe it or not.
And so I strongly believe in this approach, and we constantly argue about which approach is, better, or which approach is recommended by the guidelines.
Now, when we disagree about approaches, however, it's not the difference between getting test results in the office and getting test results later. Our differences have more to do with traditional versus being on the frontier. You tend to theorize about causality, and you look at the latest studies, for example, at the NIH, whereas I look at the standard recommendations and on, for example, UpToDate. So you have saved a lot of lives by approaching things your way. Your approach works beautifully. It's just that you're on the frontier a lot of the times. When I think something might be a little exotic, I refer to an outside specialist. And you do referrals too, but you actually know a lot more than I do about some of this frontier stuff. You handle it yourself, which is good.
The reason why I do it, because I noticed that when I order consultation with the specialist, sometimes this consultation doesn't happen for the next, 2 to 6 months.
I know, it's awful. The
And,
specialists are often not available.
And so instead of waiting for the patient to get the consultation, then to start workup, I just do the workup myself. And then by the time my patient get an appointment, they already have everything done pretty much, and the diagnosis can be made ahead of time and save a lot of time for the patient.
Right, and I'm learning from you in that regard. I'm starting to do a lot of workups myself in advance of the patient going to see the specialist, and it's very exciting. It's very exciting. We should also explain that your practice started out as urgent care, but now you do primary care as well. So in the typical urgent care practice, they don't do what you do because they don't see themselves as an ongoing patient. There's no continuity of care to speak of. You just see the patient in urgent care, you do what you can, and then you refer them back to their primary care provider or to a specialist. You don't order things and then get results later and then act on them so much in the typical urgent care. But in your urgent care, it's also primary care, so you can do longitudinal care.
Yeah, that was one of the things that really made me change my attitude, because I used to do the same way. I used to see the patient and refer them to wherever they can go to get the next step. But then I noticed that patient comes back 2-3 months later and they still don't have anything done. And that's what made me change everything. And I thought, one of the things that we have in the current situation in medicine is that everything is delayed for, a known amount of time. We don't know. Not maybe in every practice, but in a lot of practices, everything is delayed. So the patient is sick, then they have to go get some blood work, then they ordered x-ray, then they ordered CAT scan. You can get CAT scan for 2 months, then you go to the specialist, that's another 3 months. And unless they go straight to emergency room, nothing is done very quickly. And when I realized that, I thought you can actually save time, money, and the lives by speeding up everything and just be very proactive about the symptoms and just know what to order, how to speed it up, and rule out all the other unknowns so you can concentrate on the main problem. And for example, going back to that lady, I looked at my ultrasound and I noticed everything is normal. Everything, the gallbladder, the kidneys, the ovary, everything. So I know it's not a problem. So it's got to be something intestinal, because I don't see intestines on the ultrasound.
So you've already ruled out a lot of possible problems, yeah.
Yes, that's the way I approach. So
there's another thing I wanted to say is that you have quite a large patient population that doesn't have insurance or doesn't have access to medical care. And so I think a lot of what you do in terms of being thorough up front and doing the jobs that I normally would refer to specialists for, because you know that your patients aren't going to go see specialists if you refer.
right.
They only want to see you. A lot of them don't even speak English. By the way, one thing that's similar in our two practices is we both speak Spanish. In your case, you did it as on your own while practicing. You learned Spanish, over the years, and now your Spanish is excellent, and you taught yourself, which is just amazing. I had the benefit of being educated in Spanish when I was in the Army many, many years ago at the Defense Language Institute in Monterey, California, which is a fabulous place to learn languages. But I think you have to be part of the government to go there, or I would go again.
Yeah, so I think this is the beginning of the very good conversation of how I can change my system of evaluation, how I can benefit from your system and how you can benefit from my system, so we can change the way we evaluate any patient and help the patient to be on top of their health. And so one more question. So what are the health indices that you recommend to watch for your patients?
Basically, we check out, I like to rule out diabetes. So I do a hemoglobin A1C as a screen for diabetes. I do a screening lipid panel. And based on age and gender, we might have other things. For example, in men who are 55 to 69, we do PSA, which is a prostate cancer screening blood test. When you say indices, I guess you're talking about labs. But the things that...
Right.
Yeah, that is one difference between us as well. I think you tend to order more of a battery of tests because you have them all right there in your office, whereas I tend to not order labs unless they're indicated, rather than ordering a whole bunch of labs and seeing what pops up. Because, well, for one thing, insurance doesn't usually cover a test that doesn't have a specific reason. Now, they'll cover screening for diabetes and cholesterol, but in a lot of cases, and I don't want the patients to be left with a bill, unnecessarily. So I don't tend to just order a comprehensive metabolic panel unless there's a specific reason. Sometimes I'll find a reason. That will, by the way, the comprehensive metabolic panel tells us the status of the kidneys and the liver, and it also has a blood sugar in it. So that's kind of nice. And then a CBC, complete blood count, that tells whether a patient is anemic. But I won't typically order that unless they either have an acute infection or more commonly they complain of fatigue, which a lot of people complain of. So if they complain of fatigue, then they get a huge battery of tests from me. And then a urinalysis is something I would not order unless there were symptoms. So you might, on the other hand, you might have a patient and just see him for a physical exam and get a CBC, CMP, urinalysis.
Yes, when I do the physical, I do CBC, CMP, urine analysis, but I also check thyroid panel because I noticed that thyroid is much more common than anemia, and so it makes sense that why we're allowed to check CBC for people who, for the most part, don't have anemia and not allowed to have thyroid, which is very, very common. So I check thyroid panel. I also noticed lately that a lot of my patients have vitamin B12 deficiency.
Yes, that's right. The vitamin deficiencies. Vitamin D deficiency is even more common in my patient population than B12, but I have a lot of patients with B12 deficiency too. Yeah.
So I check that, and then also in terms of iron, it's not just deficiency that I'm looking for, but I'm also looking for iron overload. And a lot of times, which is also bad. So I check iron on everybody, check B12 and the thyroid panel. And then in terms of cholesterol, I just expand a little bit the cholesterol panel for appropriate patients who have risk. I just check the hereditary lipoprotein A, and that gives me an idea where the arteries are. And so that's how I do that, and it becomes very, very comprehensive. And I realize that sometimes I run into the insurance resistance, but I think the health is more important than insurance resistance.
Mm-hmm. Yeah, oh yeah, you are so thorough. It's very impressive. I think it's been a great discussion. I've already learned something just from making this video about my wife's practice. Nice to meet you all.
Right, have a good day.